at all?
Not this one.
Not this one? I highly recommend that you watch this video over and over again. The videos don't start until slide 8. I know. And that's why I'm videotaping this right now in class so I can add to that. But typically the first part of this lecture is a lot of me doing drawings on the board. So if you have different colored pens, you might want to get those out. When we speak of the autonomic nervous system, we are talking about two divisions, parasympathetic and sympathetic. Your sympathetic division is your alarm response. And when you are in a fight or flight response, your body reacts in a way that we call ANS. That means all together, ANS, E-N-M-A-S-S-E, ANS. All together. Everything's online to get you out of that horrific moment. Is there a predator chasing you? You need all the photons hitting your retina, pupillary diameters as wide as it can get. You need to figure out an exit route. Your life is in danger. But once that threat is over, you should go into parasympathetic mode. Ironically, in our life, because we have chronic stress, that is causing us great illness in our life. So you definitely need to have coping measures for chronic stress in your life. You have one body and you need to take care of it. And sometimes it's very hard to think of yourself when you're so used to thinking of others, especially if you're moms, dads, in relationships. It's hard to think, I need time for myself. Because a lot of times you think you're being selfish. No, you're trying to be healthy. So from now on, you say, I'm trying to make a healthy decision. I need to reduce some of this stress from my body. Go work out. Take a walk. Go look at something that makes you smile. Me, it's the comics. I love reading the comics in the paper. That's like my routine. If I can't do it before I go to work, I do it when I come home from work, when I'm ready to put my day away. It makes me smile. I do the Sudoku, and I put my day away. It helps me decompress. Parasympathetic division is your calm blue ocean, not just when you're sleeping, but I hope right now. You should not be having a fight or flight response right now. You are safe. Yes, the material's intense, but right now we're just learning. It's not test day, not yet. It looks like I have very little to say for this lecture. It is arguably probably the most difficult of them all for lecture unit 2. Why? Many of you have not appropriately learned the anatomy of the autonomic nervous system. Where do you find it? What does it look like anatomically if I compare it to the somatic nervous system? You should have learned that in anatomy. You probably have, but maybe your instructor didn't spend 3 weeks on it like I do with my anatomy students. 3 weeks. It might have been one class time. So you might have written all this down. You might have been tested on it, but not to the degree that I need you to step up to. So I'm going to give you a real quick introduction to the anatomy of these divisions. And then when I see you again on Thursday, we're going to pick right back up from there and talk about how we can influence them with different medications. And we do that all the time in a clinical setting. In order for you to understand how the drugs work, you need to make sure you have clear as day the anatomy of these two divisions in your head. So let's start out with a comparison of these two divisions with the somatic nervous system. Now up on the screen, here is a somatic motor neuron cell body. You see we're looking at a transverse section of the spinal cord. I can see the white matter and I can see the gray matter. I'm hoping that you remember the dorsal horn versus the ventral horn. Dorsal horn, everything incoming, every sensory thing, every action potential, I should say, comes in through the dorsal root. Dorsal side is incoming. Ventral side is outgoing. That's a motor command. If I say motor, it's synonymous with efferent. I will say efferent, even though that's not how we pronunciate it. It's efferent, but I'm going to say efferent because then on the recording you know what I'm saying. Efferent versus afferent. Very clear. But it should be afferent and efferent. Any motor outgoing command. If I say somatic motor, immediately, somatic motor outgoing command to a voluntary effector. That's what those words should immediately mean to you. And in your head you're thinking acetylcholine is being released onto skeletal muscle. A voluntary effector. An effector is something in your body that will respond to a command. Class, raise your hand. Good, you're effectors. You responded to my command. Good job. There are involuntary effectors. You have no conscious control over them. Involuntary effectors include smooth muscle, like what we discussed with the eye, cardiac muscle, glands, and adipose tissue. Those are your involuntary effectors. Smooth muscle, cardiac muscle, glands, adipose tissue. They should rattle off your tongue from now on when I say are involuntary effectors. Now, involuntary effectors, they're going to get a motor command as well. But we don't say somatic motor. Somatic motor means voluntary, conscious control. Instead, they're going to get a visceral motor command. If I say visceral motor, immediately in your head, you should be thinking, oh, Kara's talking about the autonomic nervous system, which targets involuntary effectors, like smooth muscle, cardiac muscle, glands, adipose tissue. Now the question is, where do we find the autonomic nervous system? What does it look like compared to the somatic motor nervous system? Well, a motor neuron will target skeletal muscle. It's one neuron targeting the effector. If I want to target involuntary effectors, I need a 2-neuron chain. Do you remember the general term that we call the first neuron? Presynaptic. And the second neuron, postsynaptic. But this second neuron is presynaptic to the involuntary effector, isn't it? So that's all relative. When we speak of the 2-neuron chain in the autonomic nervous system, we need to be more clear. We should not use general terms. Instead, we use preganglionic and postganglionic neurons. The preganglionic neuron, its soma, is always found in the central nervous system. Always. It terminates on the postganglionic cell, which is always found outside of the central nervous system. It's always found in the peripheral nervous system. A ganglion, the definition of a ganglion, is a collection of neuronal cell bodies outside of the central nervous system. These ganglia are found in specific places in your body. Where? Well, it depends on which division we're talking about. That's the anatomy you should have learned. I don't know how well you learned it, if at all. So we're going to have a crash course today on where you find these. Where do they live in your body? And I got to tell you, some of these ganglia are so big, you can hold them between your fingertips. You can see them with your eye. These are not microscopic structures all the time. I have my students dissect it out in the cats so that when I lecture on it, I say, see, here's a ganglion. Look at it. Hold it between your fingers. You can feel it. You can see it. Here's another one. Look at that. When I lecture on it and I say ganglia, now you have a visual. They're not all microscopic. Now, if you want to see a ganglion, you let me know, and when we open up the cats and we start those dissections, I'll bring you into the anatomy room after class and I'll show you a ganglion. That'll be towards the end of lecture unit 3 by the time we get to that point in anatomy, but I can show it to you. These are not all microscopic structures. Some ganglia, you would need a microscope. Some of them you can see, you can hold, you can dissect out. Now we need to talk also not only about where they're found, but which neurotransmitter do they release? And what receptors do they have to respond to these neurotransmitters? That's where it requires a lot of memorization. You're seeing down here the definition of a nucleus or a horn or a column is a collection of neuronal cell bodies inside the central nervous system. Brain nuclei. Nuclei in the brain are a collection of neuronal cell bodies with a similar function. For example, the cardioacceleratory center in your medulla oblongata is a nucleus. What do you think it does? It increases your heart rate. Its name tells you what they're going to do. Cardioinhibitory center. What do you think that nucleus does? Reduces heart rate. Horn, ventral gray horn. That's where we find somatic motor cell bodies. So a nucleus or a horn, a collection of neuronal cell bodies with a similar function. How are they similar? Well, this is where I'm going to go to the board and draw some things on the board. And what I'm about to draw, oh, I see Tabitha already has. I'm going to be recreating these pictures that I have posted on Canvas on your lecture 2. It's underneath the link for the videos. If you keep going, it'll say ANS drawings. So all of this is there for you. There is one error on this picture you need to make. So if you don't have this picture, write down in your notes, the one error that I have is on the parasympathetic side. I have lung, and then it says increased bronchial dilation. It should be decreased. Another way of saying that is we have bronchial constriction. And I'll explain what that is in just a moment. Let's first do the parasympathetic division anatomy. If you have your colored pens, the parasympathetic division is called craniosacral in origin, meaning that's where you find the first cell body, either in the brain in nuclei or in the sacral spinal cord. That's what we mean by origin. So this part that I'm drawing here, let this represent the brain. And this box down here that I'm drawing, let that represent the sacral spinal cord. What level are we at in the sacral spinal cord? This is S2 to S4. 4. There are 4 sets of preganglionic cell bodies that are found in nuclei of the brain. You do not need to know the names of these nuclei. They have names like superior salivatory nucleus, inferior salivatory nucleus. You do not need to memorize these nuclei. That's not what we should be doing right now. These 4 nuclei correspond to 4 cranial nerves, 3, 7, 9, and 10. Oh boy, what does that sound really close to? Doesn't that sound dangerously close to your clotting factors that require vitamin K? Don't screw that up. It's 3, 7, 9, and 10. Now just to remind you, cranial nerve 3 was called the oculomotor neuron. The oculomotor neuron. Cranial nerve 3 innervates the smooth muscle of your iris. Cranial nerve 3, but it doesn't innervate those smooth muscle fibers directly. Cranial nerve 3 exits and will synapse on a postganglionic neuron, which will then innervate, for example, those sphincter muscles of your eye that cause pupillary constriction. And cranial nerve 3, along with its postganglionic partner, being called the oculomotor neuron, is going to innervate the iris, but also the ciliary body. Do you remember that? I told you about that today. It's smooth muscle that actually has ligaments that anchor to your lens. So that cranial nerve 3 plus its partner targets the smooth muscle in your eye. What does the first neurotransmitter work? What will the first neuron release as a neurotransmitter? Acetylcholine. What receptor will the downstream neuron express on its soma? Nicotinic acetylcholine receptors. What will the second neuron release onto the involuntary effector? It will still release acetylcholine. But what receptor type will be on the involuntary effector? Muscarinic acetylcholine receptor. Remember, that's metabotropic. And you learned today that metabotropic receptors use second messenger systems. Which second messenger system does muscarinic acetylcholine receptors use? I'll remind you, the IP3, DAG, calcium pathway. Now we have cranial nerve 7. Cranial nerve 7 also releases acetylcholine. Look, all of the preganglionic fibers, are going to release acetylcholine. All of them. And all of the postganglionic somas are going to have nicotinic acetylcholine receptors. So I'm not going to take the time to redraw this every time. They're all the same. All of them the same. Now cranial nerve 7, along with its postganglionic partner, cranial nerve 7 is going to target your lacrimal gland, your submandibular glands, and your sublingual glands. So when that happens, with its postganglionic partner, Here's my picture for glands. Okay, that's my picture for gland. So that will be lacrimal, your tear production, and your salivary glands. But only 2 out of the 3. Submandibular, sublingual. Again, what neurotransmitter is released? Acetylcholine. What receptor will these involuntary effectors have? Muscarinic acetylcholine receptors. What about cranial nerve number 9? It, along with its postganglionic partner, will also target some glands, specifically your parotid. Cranial nerve 10 is considered to be, by some physiologists, the parasympathetic division. The parasympathetic division. Why would they give that title to one cranial nerve when clearly there are others and even sacral spinal nerves that are part of this division? It's because cranial nerve 10 is going to target, with a postganglionic partner, so many things in the body. For example, it will have postganglionic partners that target cardiac muscle to lower heart rate. It will have postganglionic partners that target your lungs. Here's the cardiac notch here. So those are my sad pictures of lungs. And it will cause decreased bronchial dilation. Remember, that was the correction I need you to make on your picture. It will also have postganglionic partners that target glands, like digestive glands. And it leads to increased secretion of digestive enzymes. But cranial nerve 10 can only extend so far down into the abdominal cavity. It is the only cranial nerve that extends into the abdominal cavity. It can only reach to the left colic flexure. What does that mean? So here is your large intestine. I'll remind you that it has an ascending, a transverse, and a descending. So here's your appendix. Here's the ileocecal valve. And you have smooth muscle called tenea coli. Here's the sigmoid colon, and down here you can see the anus. Cranial nerve 10 can only reach down through your body. Here's your neck. There's a reason why I'm not an artist. It can only reach, here's your intestine. Cranial nerve 10 can only extend from the brainstem, and then it comes almost to your smooth muscle and glands in your intestines before it has to synapse with its postganglionic partner. Cranial nerve 10 with its partner can target all of your small intestine, all of your stomach, your ascending and transverse colon. But as soon as you hit the left colic flexure, that's it. You need a new group of neurons to target anything in the pelvic bowl. And that's where your sacral spinal equivalents come into play. They have a preganglionic fiber that will synapse to a postganglionic neuron that will target smooth muscle, anything in your pelvic bowl, like your bladder. Remember, peeing micturition is under control of your parasympathetic division. That would not be under control of your cranial nerve number 10 because it can't reach to your pelvic bowl. That you would require sacral spinal nerves. What neurotransmitters does the preganglionic fiber release? Acetylcholine. What receptor is on the postganglionic fiber? Nicotinic acetylcholine receptor. What neurotransmitter will the second neuron release? Acetylcholine. What kind of receptor is on the involuntary effector? Muscarinic acetylcholine receptor. The parasympathetic division is very simple and easy because it's so consistent. It's one metabotropic receptor you need to worry about, second messenger system being IP3, DHE, and calcium. The receptor types on the involuntary factor never change. It's a very easy division. Now, the sympathetic division is a little bit more complicated. The sympathetic division is called thoracolumbar in origin. Now, for the interest of time, I'm just going to quickly go back to our PowerPoint. Yes?
So why is it that it needs to go through the sacral region to reach that, but it doesn't? Vagus nerve goes all the way down to the testes and ovaries.
Vagus nerve does not go to the testes and ovaries. That's in the pelvic bowl. Great question. That would still be the sacral equivalent. Now, hold on. Time out. Strike that. The testes originate actually up in the abdominal cavity near the kidneys. So I understand why you asked that question. But for us, for testing purposes, anything in the pelvic bowl and below, we're going to say sacral spinal equivalence. Because most people don't remember that the testes originated much higher up. So for testing purposes, I'm going to ask you to say sacral spinal equivalence. Okay? All right. Now let me just make sure that I got everything from your picture. That sacral spinal cord area, S2 to S4, has a special name called the sacral lateral gray column. And when we talk about the parasympathetic division, you should be understanding that it's targeting smooth muscle, cardiac muscle, and glands. Nowhere on your picture did I draw adipose tissue, did I? Nowhere did I draw that. And yet I listed adipose tissue as an involuntary effector. Adipose tissue is targeted by the sympathetic division, not the parasympathetic, which is awesome because if we think about when we sleep at night, our heart rate drops. We wouldn't also want the parasympathetic division to cause us to gain more fat and wake up more blubbery the next morning than how we fell asleep the night before. So we're glad that the parasympathetic division does not target our adipose tissue. So we just went over parasympathetic division. Parasympathetic division is going to target smooth muscle, cardiac muscle, and glands. So will the sympathetic division, but we're going to add one more involuntary effector for the sympathetic, and that's adipose tissue. Both are on all the time. By that I mean they're spiking action potentials all the time. They both have, the proper word is tone. Tone. There's always sympathetic tone. There's always parasympathetic tone. They're both on all the time. But I will ask you to recognize, when does one division have more control than the other? When does one have more control than the other? Right now, which division has more control over you? I hope parasympathetic division. I hope none of you are having a fight or flight response right now. Both divisions are going to have a 2-neuron chain. Here's the preganglionic neuron, here's the postganglionic neuron. Both of them, the preganglionic neuron is going to release acetylcholine. That will not change. Both of them, the receptor on the postganglionic neuron is going to be nicotinic acetylcholine receptors. That will never change. In this picture, you're seeing a parasympathetic pathway with 2 neurons, and over here on the left side, a sympathetic pathway, again with 2 neurons. They both have a preganglionic fiber and a postganglionic fiber. How do they differ? Well, right now, you're just learning that the parasympathetic division has distinct locations in your body. Cranial, sacral, for the preganglionic fiber. That's the anatomy you should have learned. Where do you find the neurons? Where do you find the pre? Where do you find the post? Well, let's talk about the postganglionic fiber. In my picture, I drew that in green on the board that we just went through. Where do we find postganglionic parasympathetic cell bodies? We say, it's outside the central nervous system. We say they're found in terminal ganglia. That means they're found within the wall of the involuntary effector. Do you see the smooth muscle shown here of the intestine? Do you see the cell body is within those fibers, like right its neighbors? Terminal ganglia are found in the wall of the involuntary effector. I can show you parasympathetic postganglionic neurons, but I would need a microscope. And I would get a slide of the small intestine, and I would show you the myenteric layer where you have smooth muscle, and I can show you the postganglionic neurons through the microscope. Those you need a microscope to see. And if you want to see them, I can take you to the anatomy lab at some point and show you slides where you can see the postganglionic parasympathetic neurons. What is different between the two divisions? Not only where we find the pre- and postganglionic cell bodies, which we're just beginning to relearn, but the length of those axons. The length of the preganglionic fiber for the parasympathetic division is very long. If you think about the cranial nerve 10, for example, having to come all the way down to your ascending colon, that's a long distance. So they have long pre, and because the postganglionic fiber is in the wall of the involuntary effector, we say they have a short post. The sympathetic division has a shorter preganglionic fiber and a longer postganglionic fiber. So they're kind of flip-flop. The neurotransmitter released by the postganglionic fiber in the sympathetic division you will see on Thursday is different. And the receptors on the involuntary effectors aren't muscarinic. Most of the time, they're adrenergic. Can there ever be muscarinic? Yes, there's an exception I need to teach you about on Thursday. Sympathetic division targets smooth muscle, cardiac muscle glands, but also adipose tissue. And in Unit 4, you will learn that the sympathetic division innervates the kidneys, blood vessels in the kidneys, but not the parasympathetic division. And here's my sad picture. This is what I drew on the board. You try and draw a spinal cord using your mouse. That's my dorsal and ventral gray horns. Here's my sympathetic preganglionic fiber, my sympathetic post, which is longer. Here's the brain. Can you see the lateral ventricles? These are representing nuclei in the brain. You try it with a mouse drawing this. Here's my long my short post, and I drew on the board which receptors they are going to have. Now I'm going to end there, and when we come back on Thursday, we're going to draw on the board the sympathetic division and continue this lecture with all the drugs. Also on Thursday, you have a quiz on metabolism. We'll review that. Also on Thursday, we have to start the digestive system, which is not very hard. And all of those are already YouTube videos should you want to look at them. We also need to talk about the PhysioX that I assigned. There's a lot to do. Your quiz on Thursday has 24 questions. In order for you to get the full 5 points of extra credit on Lecture 2, you need to get 15 out of 24 right. 15 out of 24 right. And if you look at your homework packet, you'll see in your homework packet an old metabolism quiz. There's a new metabolism quiz you're getting on Thursday. It's very similar, but don't let words screw you up. You should know aerobic versus anaerobic respiration. You know that cellular respiration begins with glycolysis, which is technically anaerobic, but then leads to Krebs cycle and the electron transport chain, which is aerobic. You should know what you begin with and what you end with for each of those 3 processes, and same with beta oxidation. Good? It is a lot, I know. I'm trying to pack it in before the weekend. That's my goal. All right, I will see you on Thursday. So now I'd like to pick up on the drawing for the sympathetic division. The sympathetic division is much more complicated than the parasympathetic division. And it's complicated for a few reasons. One, we have a lot of different places where we see the postganglionic cell. In the parasympathetic division, it was in the wall of the effector. And we call those terminal ganglia. So it's more confusing because there are more places we have to learn where we find the location of the postganglionic cells. Number 2, it's more complicated because it uses a lot more receptor types. It doesn't just use one receptor on the effector cell like we saw with the parasympathetic, using muscarinic acetylcholine receptors. We have 5 different adrenergic receptors that I'm asking you to know for the test. Alpha 1, alpha 2, beta 1, beta 2, and beta 3. And then the third reason why it's more complicated is because there are some exceptions. There are some quirky issues with the sympathetic division. So that's the reason why it gets really, really complicated. Can you see? Yeah, can you see the picture? Okay. So let's go through the easiest setup first. Let's entertain the exceptions a little bit later. First, the sympathetic division is called thoracolumbar in origin. That is because this is where we find the preganglionic cell bodies. They are found in a lateral grain horn. But where in the spinal cord do we find them? At levels T1 through L2. The lateral grain horn in that region has been given a special name by anatomists called the intermediolateral cell column, IMLCC, intermediolateral cell column. So if I were speaking to an anatomist and I said, let's talk about the IMLCC, to an anatomist and even a physiologist, if I just say IMLCC, boom, right away, they would go, great, we're talking about the sympathetic division, specifically the preganglionic cells. What do you want to know? Just that one term, IMLCC, says all of that to an anatomist and a physiologist. The preganglionic fiber exits and will terminate on a postganglionic neuron. That's the same pattern that we saw with the parasympathetic division. It's a 2-neuron chain. It releases acetylcholine. That's the same as the parasympathetic division as well. The postganglionic cell has a nicotinic acetylcholine receptor. That's the same as what we saw for the parasympathetic division. The postganglionic neurons can be found in the following places. They can be found in collateral, also known as prevertebral ganglia. These you can see with your eye. These I can take you to the anatomy room when we cut open the cats, and I can show you them. You can see them. You can take your tweezers and hold them up. These are not microscopic. These collateral ganglia are found on the top of major blood vessels in the abdominal cavity, specifically on top of the celiac trunk, on top of the superior mesenteric artery, and on top of the inferior mesenteric artery. And of course, the ganglia were named for where they're found. Celiac ganglion, superior mesenteric ganglion, inferior mesenteric ganglion. Another place where we find the postganglionic cells is on the paravertebral ganglia, also called as the sympathetic trunk ganglia. In the sympathetic trunk, by the way, you have two of them that go all up and down next to the vertebral column. They are also visible with your eye. You can pick that up with tweezers. These are not microscopic structures. So those are places where we find the postganglionic neuron. Now, what neurotransmitter is usually released by the postganglionic fiber? Those are our catecholamines. Remember, norepinephrine and epinephrine are chemically different by a methyl group, but they're both catecholamines, so I have both listed up there. You heard me say reason number 2 that the sympathetic division is more complicated is because it has different adrenergic receptors. Tabitha graciously acted out those receptors. Beta 1, how many hearts do you have? 1, and it beats for you, so I remember B for beta and B for beats, and I have 1 heart. How many lungs do you have? 2, and that means you have the beta 2 receptor on the smooth muscle found within your lungs. I think B for beta, and I think B for breathe, and I remember 2 because I have 2 lungs. I actually asked someone, how many lungs do you have? And they're like, 1. I said, you might want to go back to anatomy. And the person was like, I had to get a lung removed. I'm like, oh, okay. Never mind. You're right. So, I know. So, smooth muscle, it depends on where you are. That's why I have up here the receptor can be variable. If it's the smooth muscle in the lungs, it's beta 2. If it's smooth muscle in the gut, then it's alpha 1. If it's smooth muscle on most blood vessels, it's alpha 1. So smooth muscle gets a little tricky for us because on it depends where you are, what receptor you're going to find. And it gets even more complicated, you're going to learn today, that you can actually find beta 2 and alpha 1 in the smooth muscle of blood vessels, both of them. And alpha 1 causes vasoconstriction. And beta 2 is your muscle relaxer. So beta 2 in blood vessels causes vasodilation. What's a blood vessel to do if there are both? Should I constrict? Should I dilate? What should I do? And we're going to find out that it's based on how much epinephrine is released. Again, sympathetic division is more challenging because there are all these quirky little, it depends, where are you, which receptor? It's not clean and simple like the parasympathetic division. Glands. This is my picture for a gland because most of them are coiled. If it's the digestive system glands, we find alpha 1 receptors. But you're going to see over here, if we're talking about sweat glands in the dermis, totally different. Totally different. I'll get to that exception in just a moment. Adipose tissue, beta 3. I think B for beta and obesity. And we have a lot. How many fat cells do you have? 3. At least that's what I would like to think. No, we have a lot more. Probably 3,000. Anyway, even then that would be pretty good. So that is our sympathetic division anatomy review. Now let's do the quirky exceptions. Here's a preganglionic fiber, and this is my sad picture of a kidney with the adrenal gland on top of it. The adrenal medulla. The preganglionic fiber releases acetylcholine onto the adrenal medulla, and those cells release epinephrine into the bloodstream, which makes students think that this violates the 2-neuron rule. No, it doesn't. The adrenal medulla is the postganglionic neuron. Those cells collectively are modified postganglionic neurons. So it's not violating the 2-neuron rule. The cells that have been modified in there, we now call them chromaffin cells. So it looks like it's an exception, but we need to remember the adrenal medulla is the postganglionic cell. A whole bunch of them. Another exception you need to know is preganglionic fiber releases acetylcholine. Postganglionic neuron has nicotinic acetylcholine receptors. That's what I've drawn up here. And when we're talking about postganglionic fibers that are getting to involuntary effectors in your skin, the dermis, the second ganglion releases acetylcholine. I've drawn it here as blue. And that means these involuntary effectors have to have a receptor to respond to that acetylcholine. And the receptor they have is muscarinic acetylcholine receptors. Why did this happen? Couldn't the sympathetic division just get its story straight and stick to adrenergic signals and receptors? When you were first developing, the nerves that serve the body wall, the dermis, they actually grew as parasympathetic in origin. That is the reason why we see the acetylcholine dumped onto the involuntary effectors, which have muscarinic acetylcholine receptors. That originally, that embryonic origin was everything parasympathetic. But as you continue to develop, the sympathetic brain centers took over those nerves. If it could talk, it would say, thank you very much, parasympathetic division, for doing all of the work and growing these nerves, but we're going to take over from here. We're going to be in charge of these involuntary effectors. Wouldn't it be weird, stop and think, wouldn't it be weird to be sweating profusely right now? An arresting and digesting calm blue ocean moment? To be dripping with sweat? That'd be weird. To have goosebumps all the time, even when sleeping. That's the piloerector muscle. Wouldn't that be weird? So it's kind of better, if you ask me, that those things are taken over by the sympathetic division, that we break out in a profuse sweat when we have a near crash incident on the freeway, that we get goosebumps when we're scared and alarmed. Now, the goosebumps really don't help us in a threatening situation, but if you think about other animals that have a lot of fur, when they feel threatened, when they're in an alarmed state, their fur stands up and they look big, they look poofy, right? And then that means they might be able to scare off whatever is threatening them. So they get real big and poofy with their fur. How cool would that be if we could do that with our hair? Like, phew! Boo! Phew! That'd be fun, huh? I think so. So I'm going to go back to the PowerPoint now that we have our drawings done. Yes.
You have the parasympathetic. This is
This is sympathetic.
I'm sorry, paravertebral.
Paravertebral is sympathetic trunk ganglia.
And it's releasing norepi.
Norepi. So these two are still the same.
Okay. And the receptors on those are
Still, it's always nicotinic acetylcholine receptors.
nicotinic
Always.
on the glands in the atlas.
No, on the postganglionic cell, it's always nicotinic acetylcholine receptor. If you're talking about the involuntary effectors, it depends on where are you. Are you talking about the heart? Then it's beta 1. If you're talking about smooth muscle in the lungs, then it's beta 2. Okay. I won't erase it. Okay. So, we have talked about how these two divisions are similar. They both have a 2-neuron chain. They are on all the time. We don't say, when is your sympathetic division active? During the 4 Fs, fight, flight, freeze, sex. No, it's on all the time. It's just about how intense is it on, like what is its tone. But they both are on all the time. It's really a question of which one has more control over you at any given moment. They both release acetylcholine from the preganglionic cell, and they both use nicotinic acetylcholine receptors on the postganglionic cell. How are they different? We can't really say one division is always stimulatory and the other one is inhibitory. It depends on where you are. You can't always say sympathetic increases everything. It increases heart rate and force of contraction. Heart rate is chronotropy. Force of contraction is inotropy. It does increase breathing rate and depth, but it doesn't increase gut motility. It decreases. So we can't speak in absolutes for these divisions. You have to say, where are we in the body? What involuntary effector are we talking about? The length of their pre- and postganglionic fibers are different. Parasympathetic has long pre and very short post because they're already in the wall of the involuntary effector. The sympathetic has short pre and longer postganglionic fibers. We also see a difference in them in the neurotransmitter that they release from the postganglionic cell. And we also know that they have different receptors, right? Parasympathetic, real easy. It uses muscarinic acetylcholine receptors on all of the involuntary effectors. It's very easy that way. The sympathetic division has 5 adrenergic receptors, and then when we add to it the dermal effectors, we recognize that it uses muscarinic acetylcholine receptors on the dermis. So they get quirky. And we also see another issue. Some organs are only innervated by sympathetic division exclusively. For example, the kidneys. And even some tissue types can have exclusive innervation, like adipose tissue. This is my sad attempt at drawing the pre- and post-ganglionic fibers. For up here, sympathetic. This is supposed to be a transverse section of the spinal cord. And this is supposed to be a transverse section, not transverse, I should say coronal section through the brain. See, those are the ventricles. Just to remind you that the sympathetic division is thoracolumbar in origin, meaning that's where you find the preganglionic fiber bodies. And the parasympathetic is called craniosacral in origin. Comes off of the 4 nuclei from the brain and the sacral lateral gray column at levels S2, S3, S4. All right, characteristics of them. Both of them, again, release acetylcholine. Both of them release acetylcholine from the preganglionic fiber. For parasympathetic, it releases acetylcholine from the postganglionic fiber, with very rare exception. For ladies, there's no exception for you, but if you're a man, the corpora cavernosa, those parasympathetic postganglionic fibers release nitric oxide. I do not test you on that little tidbit of knowledge. I'm just tying it in with Tuesday's lecture when I told you about Viagra and how it helps with erectile dysfunction. So that's me tying it in. Postganglionic sympathetic nerves, they're going to release adrenergic neurotransmitter most of the time, but there are exceptions, and I told you about the body wall, and that's the one I do test on. Both of these divisions do have sympathetic tone. They are both on at the same time. It's just a matter of which one has more control over you at any given time. Some involuntary effectors have exclusively one division innervating them. And then we have some involuntary factors where we have mostly one division innervating them. For example, blood vessels. Whenever we're speaking about blood vessels, we're really addressing sympathetic tone. If you want more vasoconstriction, then the sympathetic tone needs to go up. The neurons fire more. The smooth muscle contracts more, and you get a narrowing of the blood vessel. So when we're talking about blood vessels, both in this unit and as we continue on in the third, I want you to remember that it's mostly sympathetic tone that we're addressing when we're talking about vasoconstriction or vasodilating our blood vessels. When we're talking about the GI tract, even though both divisions innervate the GI tract, most of the time we're in a resting, calm blue ocean state. So when we speak of the GI tract, we're really addressing parasympathetic tone. It has the most control over those organs. Not always, but most of our daily life, we're in that calm blue ocean mode. We started to learn about the eye on Tuesday. Remember I drew on the board the iris of the eye? Do you remember that there are two different types of fibers in the iris of the eye? Two different kinds of smooth muscle arrangement. What were they? The circular ones, which are the sphincter, which would cause pupillary diameter to decrease. And then we had the radial ones that they were like a bike, spokes of a bike wheel. So when they contract, they pull open the pupil and we get increased pupillary diameter. What receptors would be found on those smooth muscles? Well, on the sphincter one, muscarinic acetylcholine receptors. On the radial fibers, what would we find? Alpha 1. So the smooth muscle in your iris that responds to the sympathetic division, the receptor is alpha 1. We also started to learn on Tuesday about drugs. Atropine. Do you remember what atropine does? It blocks muscarinic acetylcholine receptors. If I put atropine on your eye, what do you think your pupillary diameter would do? Increase or decrease? Increase. So look, here's our game. Let's say this hand is sympathetic. This hand is parasympathetic. If I want more sympathetic output in my patient's body, I have two choices. I can either directly stimulate the sympathetic receptors, giving more control to the sympathetic division, or another choice is to inhibit parasympathetic influence, indirectly giving more control to the sympathetic response. It's a lot like if you went to your bathroom and you turned on both the hot water faucet and the cold water faucet equally halfway. What would the water feel like? Lukewarm, right? If you wanted more heat to that water, what could you do? turn down the cold, turn up the outflow from the hot, right? And if you did both, the water would certainly get very hot, wouldn't it? Clinically, we go that route. We go after both. If I want to get someone's heart rate going, because they're coding on me, I can give epinephrine, stimulating the receptors in the heart directly. I also can inhibit parasympathetic influence by giving atropine. Get the atropine, get the epi, get the atropine, get the... Now it's like turning up the hot water and shutting off the cold. We go after this medicinally all the time. Good? Glands of the body, okay, again, same game. Where are we? Are we talking about glands of the GI tract? Because in the GI tract, for parasympathetic, it's muscarinic acetylcholine receptors. Are going to, for sympathetic, are going to have alpha-1. Are we talking about sweat glands in the dermis of our skin? Well, then it's muscarinic acetylcholine receptors. Again, we have to play that game of where are we? Where are we? The autonomic nervous system, continued. GI tract, again, parasympathetic, very easy. We're talking muscarinic acetylcholine receptors. If stimulated, we would get an increase in gut motility. If the sympathetic division gains more control, a decrease in gut motility. Heart. Sympathetic stimulates heart rate and force of contraction, increases chronotropy and inotropy. Parasympathetic decreases. Blood vessels are primarily under sympathetic tone. If I want more vasoconstriction, I need to release more epinephrine onto the smooth muscle of the blood vessels. Again, there is an exception for blood vessels, right? The corpora cavernosa, the man's penis. But most of the time, I want you to think sympathetic for a vascular tone. We did this on Tuesday. We went through the drawings of the parasympathetic division. Talked about craniosacral, the 4 cranial nerves, 3, 7, 9, and 10. Please remember, cranial nerves 3, 7, 9, and 10 contain preganglionic fibers. They do not directly terminate on the involuntary effectors. They still need a postganglionic partner. But if I did increase the nervous activity of cranial nerve 9, then through its postganglionic partner, I would see increased parotid gland secretion. But these cranial nerves are the preganglionic component, not post. They still need a postganglionic partner. Parasympathetic division. Here are questions you should be able to answer about it. When is it active? All the time. What's the length of the pre versus post? Long pre, short post. Where do we find the locations of the cell bodies for the preganglionic fibers? Craniosacral in origin. Cranial nerves 3, 7, 9, and 10, and then the sacral lateral gray column at levels S2, S3, S4. Where do we find the postganglionic cell bodies? They are found in the wall of the involuntary effector. We find them in what we call terminal ganglia. What neurotransmitters are released by the pre and the post? Easy. It's the same answer. Acetylcholine, right? We love the parasympathetic division. I could add another bullet. What receptors do you find on the postganglionic cell body? On the postganglionic. There we go. All right. What receptor would you find on the involuntary effectors? Muscarinic acetylcholine receptors. And what are the involuntary effectors? Smooth muscle, cardiac muscle, glands. Do not add adipose tissue because it does not innervate adipose tissue. Could you do the same thing for the sympathetic division? Where do you find the preganglionic cell bodies? In the IMLCC. thoracolumbar, T1 to L2. Where do we find the postganglionic cell bodies? Well, a lot of places, and these are not microscopic structures. We find them on the celiac ganglion, the superior mesenteric ganglion, the inferior mesenteric ganglion, the sympathetic trunk ganglia, and the quirky one more, the adrenal medulla. Good, I know. How long are the preganglionic fibers? Short and longer post. What neurotransmitters are released by the preganglionic fiber? Same one, acetylcholine. But what about the postganglionic fibers? Well, where are we? If we're talking about effectors in the body wall, it's acetylcholine. If we're talking about anywhere else in the body, it's epinephrine/norepinephrine. Well, what receptors are found on the postganglionic cell? Nicotinic acetylcholine receptor. But what about on the involuntary effectors? Where are we? Are we on the heart? Because that would be beta 1. Are we the iris of the eye? Because that would be alpha 1. Are we in the smooth muscle of the lungs? That would be beta 2. Are we the smooth muscle of the gut? Then that would be alpha 1. Are we talking about smooth muscle of blood vessels? That would be alpha 1, except for when there's beta 2 as well. Are we talking about the involuntary effectors in the body wall? Because then that would be muscarinic acetylcholine receptors. It's a very complicated system. We hate the sympathetic division because it's so quirky. Now, do you want practice of what to expect with these types of questions on the exam? There is a supplement listed in Canvas. I don't know if you found it, but there's also answers to this. It says dendrites to synapse ANS supplement, and then I also gave the answers. I think the file is fine, but if it's not, I know you'll let me know. You're not shy when it comes, I need practice. It's not available. You'll see in that supplement that there is a paragraph of fill in the blanks. And it says in this supplement, consider the innervation of the bronchioles. And first question it says, to increase bronchial diameter, to have bronchial dilation, the blank division should have more control, something like that. Sympathetic. And then the questions that follow that are going to be like, what is the effector protein for this division? That's, remember, the second messenger maker. You would pick adenylyl cyclase. What receptors would be found here? You would pick beta 2. What drug could stimulate these receptors? You would pick in that example albuterol, and I'm going to teach you about albuterol. If you do not start that paragraph off by figuring out which division would need more control, poof, all the other points disappear. Now, out of a 100-point exam, this is going to be what, 14 points? Why did I say 14? Because you're going to have 2 paragraphs, 2 of these. And I promise you, one will be parasympathetic and one will be sympathetic. I promise you. Now, are you going to study and get all 14 points for that? Or are you going to be that student, there's always one in every class, where the student's like, I'm going to at least get half. I'm going to answer both paragraphs sympathetic. Which is not a bad test-taking strategy if you don't remember any of this, right? At least you'd get half. But I'd like you to get all 14 or whatever it's going to be, 12, 14, something like that. The 4 systems, not systems, but body parts I'll go after in those 2 paragraphs will be eye, heart, lungs, gut. Which means I could have 8 different tests, can't I? Nick, you might have the test that says, consider innervation of the eye. In order to get increased pupillary diameter, the blank division should be given more control. So he's like, high five, sympathetic for the eye, I'm on it. But then the next paragraph, his might say, consider innervation of the heart. In order to get a decrease in heart rate, the blank division should be in charge. And Nick is going to say, this is my parasympathetic moment. You're going to have 2 paragraphs. That supplement gives you a very good idea of what to expect. I encourage you to look at it. A lot of these drugs we've already talked about on Tuesday. We know that muscarine is a poison that will stimulate muscarinic acetylcholine receptors. Do poisons, do drugs, do they have the ability to just go to one place in the body and stimulate just that receptor just right there? No. So if you eat muscarine, it's going to go to every muscarinic acetylcholine receptor in your body and stimulate it. What kind of division response are you going to see in your patient if they ate that toxin? They are going to be oozing from every pore and orifice. Lacrimal gland secretion, salivary gland secretion, increased gut motility, increased gut secretion of digestive enzymes and juices, increased sweating. How can we help them? What drug can we give as an antidote? Atropine, to block the receptor. Then the muscarine can't get to it. Pilocarpine is another drug that stimulates muscarinic acetylcholine receptors. So it's a drug, not a toxin, but it does the same thing as muscarine. Nicotinic acetylcholine receptors, their name tells you, they can also bind to nicotine. And if that happens, then we would see the postganglionic neuron being stimulated more for both divisions. Remember, they both have nicotinic acetylcholine receptors on the postganglionic cell. We also have learned about neostigmine and pridostigmine and physiostigmine. All the stigmines are acetylcholinesterase, not temporary. They are temporary. They're not permanent inhibitors. We learned about organophosphates, DFP, and sarin gas being permanent, biologically permanent. Well, what's edrophonium? Well, that's an interesting thing to talk about. Edrophonium is an acetylcholinesterase inhibitor. It is very short lasting, wears off extremely quickly. We use it clinically for the following issue. If you have a patient with myasthenia gravis, their immune system is attacking nicotinic acetylcholine receptors, which are very abundant on skeletal muscle. We give them a stigmine. It temporarily blocks the acetylcholinesterase, allowing acetylcholine to last longer in the cleft, more opportunity to create an end potential, spike in action potential, leading to muscle contraction. The problem is, if someone overdoses on their neostigmine, they're going to go into spastic tetany. We know from our PhysioX you can't hold that indefinitely. There will be fatigue. So how would you know if both patients arrive with myasthenia gravis at the same time and they're unconscious? You have no ability to ask them, did you overdose on your drug or did you not take your drug? Because if they overdose on their drug, they're going to be like this, right, from the fatigue. If they don't take their medication, they're also going to have poor motor tone. How do you know which patient to treat with what drug? If they can't talk to you, here's what you do. You give them both edrophonium. It's a short-lasting stigmine. If the person is in a myasthenic crisis, it's because they didn't take their med. If you give them the edrophonium, their motor tone will improve. If you give the edrophonium to a person with myasthenia gravis who overdosed on their meds, They are in a cholinergic crisis. They've had too much acetylcholine. They are going to have poor motor tone because they're in fatigue. They can't hold tetany indefinitely. If you give them the edrophonium, their motor tone will not improve. That's when you know you need to give them an antidote. What can you give them? You can give them protopam. Remember, protopam competes away whatever drug is blocking the acetylcholinesterase. And you can also give them atropine to block muscarinic acetylcholine receptors, reducing one of the targets of acetylcholine. Okay? Now, I don't know which tutor is saying this, but it drives me batshit crazy every time. If you have a question where I'm asking you to explain these crises and how to know the difference, one of the tutors is saying, if you give the edrophonium to the patient with myasthenic crisis, they will, quote, wake up. Never did I say they wake up. In my example, I said, what if both show up unconscious? All I said was, if you give the myasthenic crisis patient edrophonium, I said their motor tone will improve. That's what I said. I didn't say they'll wake up. I didn't say that. I don't know. So if you write that, I'm going to say, what? What does this have to do with opening your eyes and waking up from an unconscious state? They'll have better motor tone. I think they're going with this. I think that's why they say they'll wake up. Well, being able to open your eyes is different than waking up. I can wake up and not open my eyes. You want to see me do it? Watch. I am awake, but my eyes are not open. Camera 1 and camera 2 are clearly shut. Anyway, it drives me nuts. Just don't put anything in there about waking up. Stick with motor tone. All right, and then we talked about atropine. Here are your receptors that I want you to know. They are shown here in yellow. There are different types of adrenergic receptors. I could add to the list. I don't think we need to. The sympathetic division is difficult enough. I want you to know alpha-1, where do we find it? Gut. Digestive glands, that's the gut. Smooth muscle of the gut. The iris, the radial fibers. We also find it on arteries. Alpha-2. Alpha-2 is going to be involved with negative feedback inhibition. I'll explain that in just a moment. Beta-1, heart. Beta-2, lungs. Beta-3, adipose tissue. Now, please understand, the beta-2 receptors are not exclusively found in the lung. Beta-2 receptors can be found on blood vessels. I'm going to show you that. Beta-1 receptors, not exclusively found on the heart. This is just for testing purposes. I want you to think beta-1 primarily on the heart. Beta-2 primarily in the smooth muscle of the lungs, but not only, primarily. Alpha-1, well, heck, where are we? Alpha-1, blood vessels. Alpha-1, the iris. Alpha-1, the gut. Alpha-1 is very abundant. You also should know that these different receptors have different affinities for your catecholamines. Alpha-1 and beta-1 receptors can and do bind to dopamine. Norepinephrine can get to alpha-1, alpha-2, and beta-1. Epinephrine, well, it hits all of them. That's the best neurotransmitter if you want to target all of the adrenergic receptors. What about drugs? You're going to learn about isoproterenol. It targets beta-1 and beta-2 receptors, stimulating them. What would you see in your patient? More sympathetic response. What about ephedrine? Ephedrine. There used to be a drug called Sudafed that had ephedrine basically in it. And now they had to switch to a new formula. Why? Can you still get the old formula? Yes. Yes, you can. Where do you have to go to get that though? To the actual pharmacy counter, where they will take your license and they are documenting the day you bought that, how many boxes that you bought, and they are linking it to you. You want to know why? You want to know why? You want to know why? Yes, meth. So people were going to buy this Sudafed medication and they were using it to make meth. Now you have to, they document that. Because if you're buying 10 boxes at this CVS and then at that Rite Aid and then at that other CVS, they're going to find you. They're going to say, what are you doing with all that? Red flag. So get someone else to go into hundreds of different stores and buy one box. Phenylephrine is the new formula of Sudafed. It's now called Sudafed PE for phenylephrine. It goes after alpha-1 receptors. Now we take Sudafed PE for nasal, like when we've got nasal issues, right? Congestion. Well, how does that work? You have congestion in the drippy nose because the blood vessels in your nose are vasodilated. A lot more blood, more stuffy. Can't read. Because the blood vessels, the swell bodies in your nose are swollen, engorged with blood. It's like having an erection in your nose. You take the Sudafed, it binds to alpha-1 receptors, and in those blood vessels, it causes vasoconstriction, less swelling, easier to breathe. And then down here, clonidine, I'm going to explain to you how clonidine is used to target alpha-2 receptors, which helps with negative feedback inhibition. And then albuterol is very specific for beta-2 receptors. When stimulated, that would lead to an increase in bronchial dilation. Anybody here have asthma? You've got everything. She just keeps her hand up like, myasthenia gravis. No, okay, good. Of course, she's like, I've got enough. We don't need to add to the list. Please remember, these catecholamines all originate from tyrosine, but we can go back even into tryptophan if we want to. Tyrosine gets changed into L-DOPA, which gets changed into dopamine, which gets changed into norepinephrine, which gets changed into epinephrine. Alpha-1 receptors. What do I want you to know about them? If they're on blood vessels, it causes vasoconstriction. If we're talking about smooth muscle of the gut, it will decrease gut motility. Are we talking about glands of the gut? It will decrease release of digestive enzymes. What about alpha-2 receptors? Alpha-2 receptors are found on, this will drive you nuts when you get to pharmacology. How many of you are going to take pharm next? Okay, when you go into pharmacology, forget your physiology. Just purge. Do not overthink your questions. You will if you don't purge your physiology. I want you to do well in pharm, so forget everything I teach you. And when you're done with pharm, then reload everything, okay? Just permanently download all of your physiology memory and keep it somewhere else. And then when you're done, upload again, okay? Trust me with this. In your pharmacology class, you will learn that alpha-2 receptors are on the presynaptic cell. Then you're going to read that and you're going to say, but wait, Kara told us alpha-2 receptors are found on the postganglionic neuron. Yeah, notice the difference. Presynaptic versus postganglionic. Presynaptic is a relative term. Agreed? The postganglionic neuron is presynaptic to the involuntary effector. Oh. So you all get Twitter baited when you get to pharm because you read that the alpha-2 receptor is on the presynaptic cell and you're like, no, it's on the postganglionic neuron. Postganglionic neuron is presynaptic to, let's say, blood vessels. The smooth muscle of them. So the postganglionic neuron releases norepinephrine. Let's just use that as an example. Norepinephrine can bind to alpha-1 receptors. We know about negative feedback at this moment. We know too much norepinephrine we don't want too much. We want the signal when it's appropriate, but we don't want too much. So alpha-2 receptors, they're on the terminal bouton of the postganglionic cell. Norepinephrine can also bind to those receptors. And when they're bound, this decreases the amount of synaptic vesicles that are fusing. You don't want to dump too much out. So this is part of negative feedback inhibition. You don't want too much norepinephrine dumped out. So clonidine was on there because clonidine is going to bind to alpha-2 receptors. Why would that lead to vasodilation? If clonidine binds to this receptor, then this postganglionic neuron doesn't release as much norepinephrine. Then that alpha-1 receptor won't be bound. Then this smooth muscle will not constrict. What will it do? Vasodilate. So clonidine is sometimes used to treat patients with hypertension because it will, through negative feedback inhibition, decrease the amount of epinephrine, norepinephrine released, and then the blood vessel will relax. Beta receptors, we talked about one heart, beta 1, mostly expressed on the heart, but that's not the only place. Beta 2 is your smooth muscle relaxer. If it's in the lungs, then the smooth muscle relaxes and you get increased bronchial dilation. But if it's on blood vessels, the blood vessels will relax as well. Relaxed blood vessels means more blood flow. Do you agree that if you're running for your life, you should probably have more blood flow to your blood vessels serving skeletal muscle? So they would have receptors that bind to epinephrine and that beta 2, and it would cause vasodilation. If you are running for your life, do you think the blood vessels serving your brain should remain vasodilated? True. So this vasoconstriction, vasodilation, we're going to see that there's a fight on blood vessels with alpha-1 receptors favoring constriction versus beta 2, which favor dilation. And it gets quirky. Again, sympathetic division, not our friend. Next, beta 3 receptors, when they are stimulated, they increase lipolysis, more fat mobilization. Yes, please. Can someone go to pharmacology school and learn to develop a drug that will strictly stimulate beta 3 receptors? Wouldn't that be awesome? I know. So here's that quirky fight I was alluding to between alpha-1 and beta 2 receptors on the blood vessels. Here is a scenario where we have both alpha-1 and beta 2. Alpha-1 would lead to vasoconstriction. Beta 2 would lead to relaxation. If there is a low amount of epinephrine in the bloodstream, for example, beta 2 receptors will load up, bind to that epinephrine better. They have a higher affinity. The alpha-1 receptors don't have a high affinity. They would not be populated unless the epinephrine released got in such high amounts that now all of these receptors are bound. And numbers win. There are more alpha-1 receptors than beta 2. If all the receptors are bound, then the blood vessel will vasoconstrict. If there is a low level of epinephrine, it will preferentially bind to beta 2. Then that vessel would vasodilate. Again, sympathetic, quirky division. Dopamine should also be considered in this lecture because it is a catecholamine. Dopamine, to the date, well, last time I checked, we have 5 different known dopamine receptors. I do not feel compelled to abuse you with those dopaminergic receptors and add to our quirkiness of the sympathetic division. But dopamine, I want you to know, for testing purposes, is primarily, when we're talking about the substantia nigra, an inhibitory signal. And remember, is it the neurotransmitter that dictates inhibitory or excitatory? It's the receptor type. So when it comes to your brain, I want us to focus on Parkinson's disease. The substantia nigra cells are dopaminergic, and that blocks unwanted movement. If you lose the dopamine, then you can't block unwanted movement. And what will the patient have? Unwanted movement. That's the Parkinson's tremors, right? They don't want to move that way, but they're losing the inhibitory signal from those substantia nigra cells. Dopamine elsewhere can have excitatory effects. Remember, it's the receptor. Dopamine, I'll remind you, can bind to beta-1. I showed you that on the chart. What do you think would happen to your patient's heart rate and force of contraction if you pumped dopamine into them? Beta-1. It would have an increased heart rate and force of contraction. What do you think it would do if you injected dopamine and it bound to alpha-1 receptors? Because according to that chart, it can. They're going to have more vasoconstriction. They're going to have an increase in blood pressure. So dopamine depends on where you are again. Now I'm going to focus on the Parkinson's disease. It's very hard to see in this picture, but this is a picture of a neuron in the brain. And in this neuron, you're seeing L-DOPA being converted to dopamine. And then the terminal boutons are releasing dopamine. How can we go after this system if we're talking about a Parkinson's disease patient? Well, dopamine can't cross the blood-brain barrier. L-DOPA does. The problem is it needs to last long enough to get across the blood-brain barrier. The problem is there are enzymes in the patient's blood that will degrade the L-DOPA before it can get there. So pharmaceutical companies have created carbidopa, levodopa, carbidopa, levodopa, levodopa, L-DOPA, carbidopa, levodopa. Carbidopa part is going to envelop the L-DOPA, keep it safe while it's traveling through the blood, and when it gets to the blood-brain barrier, carbidopa releases the L-DOPA, which can now enter these cells and lead to dopamine synthesis. We know, however, that these cells are still dying, and eventually the very medication that the Parkinson's disease patient needs is not going to be effective. We also know that dopamine gets degraded by monoamine oxidase. So we also should give this patient monoamine oxidase inhibitors. The dopamine that's released needs to last longer. We can think of a lot of people who have had Parkinson's disease. Who can name another person besides Michael J. Fox? Doesn't have to be currently living. Who? Muhammad Ali. Yep. Fact, people who sustain more traumatic brain injuries are more likely to develop Parkinson's disease. A lot of soccer players, for example. Right? Soccer players don't wear helmets, and yet they head the ball a lot. And let me tell you, when a goalie punts that ball and you're like, I'm going to head it, and it's coming, it hurts. It doesn't matter if you head it the right way. It's still, it like shakes your brain up. If you've had concussions, increased risk of Parkinson's disease. But anybody else besides Muhammad Ali? How about a famous actress? Female I'm thinking of. Very famous one. She was in, what was it, Golden Years? Not Golden Girls. That's a TV show. On Golden Pond, that's what it was. Thank you. And she was like this, Katharine Hepburn. She had Parkinson's disease. Yep. So our go-to for these people is carbidopa, levodopa, and MAOIs. You don't need to worry about the COMET enzyme. Also, we go after that, but I didn't tell you any drugs about that, but I did tell you about MAOIs. All right, sympathomimetics. You saw on a previous slide, isoproterenol stimulates both beta-1 and beta-2 receptors. Dopamine stimulates alpha-1 and beta-1. Phenylephrine from Sudafed PE goes after alpha-1. Albuterol can stimulate beta-2. If a patient is on any of these drugs, you need to be able to tell me, what would you see in your patient? If they are on a sympathomimetic, then you would expect to see more sympathetic control in your patient's body. I also told you about ephedrine and how that's used to also morph into amphetamines, methamphetamines, and you heard me say the old formula of Sudafed was pseudoephedrine. Drugs that block sympathetic nervous system. If you block the sympathetic, which division are you indirectly giving control to? Parasympathetic. Good. So blockers, alpha blockers, phentolamine, that was considered to be the poor man's Viagra. Still is considered to be the poor man's Viagra. I'm happy to say they can now take that orally. It used to be it had to be injected. Yeah, I know. I'm sure every guy in here is like, no thank you, I don't need sex that much. But yeah, now you can take it orally. Phentolamine is going to block alpha-1 receptors. If you block alpha-1 receptors on blood vessels, what will they do? Relax, vasodilate. Here comes more blood. Problem with this is we need to be careful because if we have too much vasodilation, especially if we're talking about a man taking a drug for erectile dysfunction, there can be a reflex increase in heart rate. That's what we call tachycardia. And the reason why their heart rate goes up is because blood vessels are dilated. If they're dilated, there's less blood coming back to the heart. Less blood back to the heart means less being ejected. And there are receptors in your aortic arch and carotid sinus that are monitoring the amount of blood pressure. Well, if there isn't enough pressure because you're not ejecting enough, because everything's in your penis for blood, right? It's not going back to the heart, it's going right there, then the heart rate goes up. And the heart rate, elevated heart rate is something to be concerned about. We're going to talk about elevated heart rate and why it can lead to a heart attack. And we're also going to do a lab on how to poo correctly. Yeah. No, it's a real lab. You thought you knew how to poo? We're going to have a lab on how to poo correctly. It's a real lab. I'm not making this up. It's a safety issue because if you are straining to defecate, your heart rate goes up. And you're going to have tachycardia, and if you have pre-existing heart conditions, you can die while on the crapper. It does happen a lot, which is why I said it's a safety issue, and I'm going to help you. If you look like this, that's not okay. So we're going to learn how to poo correctly. I'd like to think I'm going to save your life one day. If you ask anyone who works as an EMT, I love asking this question. When you are called to go pick up a dead body, what time of the day is it usually? They will say, morning. And I say, good. And where are you going to find that dead body? They will say, bathroom. I went, yep. Yeah. Elvis died on the crapper. He did. The king died on his throne. It's a safety issue. I'm going to teach you. You used to know when you were like a toddler, 3 years old, oh, you pooed like a champion. And you did it correctly. Now you're not. So we're going to have a lab in the next 2 or 3 weeks. Beta blockers. Propanolol blocks beta-1 and beta-2. If I block those, what would I see? More parasympathetic output. Reduced heart rate. The problem is with propanolol, if I am an asthmatic, that would be contraindicated because it's going to block my beta-2 receptors, and now I'm going to have bronchial constriction, and that's not okay. Isoproterenol, just to go back, if I have isoproterenol and I'm given that for asthma, well, that's great, but if I have an underlying heart condition, high blood pressure, let's say, I wouldn't want to take isoproterenol because that's going to stimulate my beta-1 receptor and lead to increased force of heart contraction. That's going to increase my blood pressure even more. Okay, that's the end, and we do have time.